Hello, everybody. Welcome to today's webinar. My name is Rebecca Jessman. I'm a research and policy analyst with the Canadian Centre on Substance Abuse. I'm going to provide a quick introduction here and then hand things over to Nancy. So just a heads up to everybody that this webinar will be recorded, that the recording and slides of the presentation will be available through the links that you see on your screen now. We'll be taking, because we have a tremendous registration for this webinar, we're asking people to enter any questions into the chat box and not to dial in and try to take questions by phone. The numbers just unfortunately prohibit that at this time. So we will have 3 opportunities for you to pose questions for Nancy to respond during the presentation itself. And we certainly welcome your feedback throughout today's webinar. We will be giving you a survey follow-up to the webinar so that we can improve the way we do this. How this came about. It's being put on through System Action. System Action is a national network of diverse individuals and organizations across Canada who are committed to developing a comprehensive support through knowledge exchange and evidence, and supporting implementation of the recommendations in the Systems Approach to Substance Use in Canada report. System Action is being coordinated by the Canadian Centre on Substance Abuse in support of the Systems Approach report recommendations and through financial support received from Health Canada's Drug Treatment Funding Program. If you'd like more information on System Action or CCSA, you can contact Rod and Jenny. All the contact information is available at the end of the slide deck. And now the moment you've been waiting for, Ms. Nancy Poole is the Director of Research and Knowledge Translation at the BC Centre of Excellence for Women's Health. She is renowned for her work on research, training, and policy initiatives related to women's substance use, mental health, and experience of violence with governments and organizations on local, provincial, and national levels. She is the co-editor of an upcoming book on trauma-informed care that will be published by the Centre for Addiction and Mental Health. I also might add that she's an active member of the System Action Network. I'll be back later in the webinar to moderate questions, but I'm now pleased to turn it over to Nancy.
Thanks so much, Rebecca. So this is going to be a great hour, I hope, to talk a little bit about trauma-informed practice. And I just wanted to mention that I'm going to be largely focusing on the circles here on the interactions with our clients and trauma-informed work and our service cultures and our interagency and intersectoral collaboration. I won't have time today to talk about that outer circle, about the importance of influencing the social conditions that create the need for trauma-informed practice, but I just wanted to start by making sure we all understood that that is definitely part of it too. So the agenda for today, I was going to take a bit of time to introduce both trauma-informed and trauma-specific practice, give a few examples of how people are embedding trauma-informed care in various settings in Canada, to discuss, why we need to focus on trauma-informed care in our systems, and definitely to sort of summarize at the end a bit about some of the key issues and themes and resources. I'm going to stop a couple of times along the way to take some questions. So if you have some, do type them into that in that Q&A box in the bottom right-hand corner of your screen. And Rebecca and Jenny, who are both at CCSA in Ottawa, will monitor the questions and help me answer them at various points. So let's just talk a little bit first off about trauma. There's so many definitions of trauma and so much important work being done on the neurobiological aspects, the emotional, psychological, etc. aspects. And we don't really have time to, go into all of that in this short piece on trauma-informed practice. But I did want to kind of point you to a great little pamphlet that CAMH did a number of years ago. Look at it, in 2000, actually, which is kind of a plain language look at what is trauma. And lots of service providers I've talked to have said they often find that helpful, this pamphlet, in explaining trauma to their clients. Now, I've spent a fair bit of time working on women's health issues and prevention of FAS and lots of different areas of women's substance use. And in the course of that, lots of us who've been working on those issues have kind of come up with this depiction of, how central trauma can be to substance use problems, mental health problems, violence-related issues. And that in turn, all of those things are connected to larger determinants of health and institutional responses. So, it's a complex territory, the links, and we don't have time today to go into all the, various, overlaps and prevalence rates of these multiple issues, but just wanted to kind of, put trauma at the center for our discussion today. Now, those of you who are, more interested in sort of evidence from the research piece, I just popped in this example of one study that shows the connections between trauma and violence and substance use and mental health concerns that Silverman and others did some years ago in the U.S., who looked at, girls who'd experienced dating violence, and there are much higher rates of all these particular health problems. And as I said, I'm not going to linger on the connections or the cross-cutting prevalences and whatever today, but just use those slides to kind of set the stage about how important trauma-informed practice is for us in our work, and to suggest that those overlaps really create the rationale for us to think about trauma-informed practice as substance use providers, to help people make the connections between their experience of trauma and problematic substance use or mental health concerns, and to really, especially because client engagement, retention, and outcomes improve when our services are emotionally and physically safe, and there are opportunities for learning and building of coping skills, and where clients have choice and control. Now, oftentimes there's a fair bit of confusion between what we mean between trauma-informed services and trauma-specific services. And, lots of great people have written on this, and you may recognize the work of Maxine Harris and Kevin Bloom and others in this quick definition here around trauma-informed services. They embed an understanding of trauma in all aspects of service delivery. They place a priority on the trauma survivor's safety, choice, and control. And they create a treatment culture of nonviolence, learning, and collaboration. So, in a trauma-informed service, people may not necessarily disclose they have a trauma history, but they are, services are provided in a way that recognize that that's a high likelihood given the strong overlap of trauma and substance use and mental health concerns. Now, trauma-specific services, on the other hand, directly address the impact of trauma and facilitate trauma recovery and healing. And I'm just going to give a few examples of trauma-specific approaches that you may recognize, like EMDR and trauma-focused cognitive behavioral therapy, et cetera. And there are a few things on this list that may also be on a continuum between trauma-informed and trauma-specific, like the seeking safety model. So I'll spend a little bit of time talking about some of those models a little farther in. So that's just the quickest overview of the connections and the difference between trauma-informed and trauma-specific. So before I go into, the sort of principles and practices of trauma-informed, Rebecca, do you feel like there are questions that we should stop and attend to right now?
Hi, Nancy. Thanks. I don't see any questions from the participants just yet. So I will just take the opportunity to remind people that you can enter any questions into the chat box that you see on the right-hand side of your screen, and there will be other opportunities through the presentation where we'll take a pause to address them.
Super. Thanks. So I have to say that this next section about key principles of trauma-informed practice has really been informed by my work in British Columbia over the last 6 months or more, where we have, as a system in BC, really been thinking together, the British Columbia government, the health authorities, and system planners, the service providers, and some of us research and knowledge translation types as well, sort of coming together to think through using a focus group, an appreciative focus group model to kind of wrestle with what do we see as the key principles, both from the literature and from our practice. So here's the 4 principles of trauma-informed practice that we've kind of defined together, that all services taking a trauma-informed approach begin with building awareness of how common trauma is, how the impact can be central to one's development, that there are a wide range of adaptations people make to cope and survive, and that the relationship of trauma and substance use, physical health, and mental health concerns is strong, and we need to, sort of acknowledge that and recognize that and make that commonly known. And so that part of the first key principle is really about trauma awareness, that it's the foundation of an organization culture of trauma-informed care. And I'll talk more a little bit about what that means for both providers and for clients as we go along. So first principle, trauma awareness. Second principle is that emphasis on safety and what Roger Poole in the States calls trustworthiness, that in trauma-informed service, trauma survivors, we recognize that they have likely experienced boundary violations and abuse of power and need to feel physical and emotionally safe and may currently be in unsafe relationships. So it's really important, I think, that final point there, that not only do people have histories of trauma that they may or may not be ready to disclose, but they also may be in currently unsafe relationships that we do really need to ask about and make sure that they're not currently in an unsafe relationship. And so that's where a kind of work on violence separates from work on trauma. In my mind, is that where there's current lack of safety, we definitely need to be asking about and supporting people to make safety plans. On the other hand, we can be working in our services in a trauma-informed way without necessarily, probing for disclosure amongst our clients. And so safety and trustworthiness are really established through welcoming intake procedures, adapting the physical space, providing clear information and predictable expectations around programming, ensuring informed consent, creating crisis plans, doing lots of different ways of creating safety. And I just want to emphasize that safety and trustworthiness is also something that's really important for the providers themselves within a trauma-informed service approach, and that, education and support related to vicarious trauma is a very important piece. So the third principle is about opportunity for choice, collaboration, and connection. And, in that sense, really, trauma-informed services create safe environments that foster a client's sense of efficacy, self-determination, dignity, and personal control. And it's in that, from that frame, service providers are encouraged to communicate openly, equalize power imbalances, allow the expression of feelings without fear of judgment, provide choices as to treatment preferences, and work collaboratively. So these are people who have been in overwhelming situations where they have not had power. And so our work to be an entirely different form of communication is critical. And finally, the fourth key principle we've thought through a bit in BC is this idea of that it would also be strengths-based and skill-building. And so, that, we know this as good practice, but really where we know that people are likely to have had a history of trauma, we really especially attend to resiliency and coping skills. We teach and model skills for recognizing triggers, for calming oneself, centering, staying present. We support that whole kind of organizational culture of emotional intelligence and social learning together. And, we do a lot of work around our own competency, around trauma-informed practice. So those are the sort of key principles we've been talking lots about in BC. I don't know whether people have questions or comments they want to make now, again, before we go into some examples of trauma-informed practice in Canada.
Thanks, Nancy. We did have one question regarding whether or not integrating trauma-informed practice into addiction treatment is a recognized best practice, so whether it's imperative to best practices.
Well, I personally do feel that it is, and that's why I've been working so, hard on raising awareness of this. If we know that this is true of a very large proportion of our clients and that it's affecting their personal, their present ability to cope, and that if it is, if their substance use is connected to, is being done as a way of coping with their experience of trauma, all of which may be, totally true, it just seems self-evident to me that trauma-informed practice would be a best practice in our work. And I'm seeing more and more written on that as time goes by. There was an article last week in one of the journals that I saw where a social worker had written that had written a whole article that said basically that this is best practice, we need to get doing it. And lots of folks like the Substance Abuse Mental Health Services Administration folks in the States, and you'll see some of the links to some of their, work on trauma-informed practice. They're very much, integrating it into the American system as a best practice. So, yeah, I think that's where we're heading. And I've included a few of those links. I don't know whether you all got this when you signed up for the webcast, but, the CCSA has just put up an Essentials of Trauma-Informed Practice kind of toolkit sheet up on the Canadian Association of, help me out here.
Canadian Network for Substance Abuse and Allied Professionals.
Thank you. I knew I would forget that. On their site, and you can download a little sheet that has some of the links to the places that are promoting trauma-informed practice as a best practice, and lots of links there.
A quick follow-up question to that, Nancy. Are there tools available for assisting an organization to create such a culture of trauma-informed care then, and to create a physical safe space within practice in order to create that?
Yes, well, there have been some created, and I've got lots of links available that to the work of groups like Community Connections in Washington, D.C., where Maxine Harris and Roger Fellow have done lots of great work on thinking through that. There are the Bloom's work in the sanctuary model has lots of ideas about that as well. So we can definitely point you to those links, and some of them are included in that Essentials of sheet. But I just want to do a little plug, I guess, again for BC, is that we are actually working on a guide for trauma-informed practice in British Columbia, and this work that we've been doing to define and think through what it is has really been lots about working towards that. So stay tuned for that work in British Columbia, because I think, there's some amazing work that the service providers and health system planners are doing in that province to come up with, a guide to it.
Thanks, Nancy. And this might actually lead into the next section, but there's also a couple of questions about vicarious trauma and giving examples of vicarious trauma. I don't know if you speak to that as you move forward, or if perhaps you could.
Not so much. That is a huge topic area, and there's a great resource on vicarious trauma on the National Clearinghouse on Family Violence website. I really encourage you to go and get it. And if, I can send it on to you, Jenny, it's to pass on to people as well if people don't have the link. But, that is a critical piece. And but I will go on now to talk a bit about examples of putting it into practice, because I do see lots of questions about how does trauma work fit into a brief therapy model, et cetera. So why don't I go on and do a bit of that, and we'll come back to some questions at the end. So hopefully some of these questions you have will be answered in these next examples I'm going to show you. Now, here's an example that emerged from some research that Colleen Dell has led in partnership with the National Native Addictions Partnership Foundation, the Canadian Centre on Substance Abuse, and where she is at the University of Saskatchewan. And she's done some really interesting research with Aboriginal women on what they see as the role of the treatment provider in supporting Aboriginal women who are healing from illicit substance use and also are criminalized and have lots of other things going on. I really encourage you to go and look at the Stilettos to Moccasins work that she has posted on her Addictions Research Chair site. But one of the things, oops, it's lost here. Oh, one of the slides isn't here. I've been worried because I have been worried that we're working with a slide deck that is not the most recent one. But the most important thing I wanted to point out was that in that work, they have come up with this sort of mnemonic called Reclaim, that talk about the aspects of what clients would like to see in the service providers. And one key aspect they mention is that the service providers will recognize how central trauma is in the lives of Aboriginal women. And so I really encourage you to go and check out that site. So that was an example of, trauma-informed practice within treatment, within intensive treatment. This, however, is just a bit of a sense of trauma-informed practice within the brief intervention model that someone asked about. And the people in British Columbia have been really talking about how consistent trauma-informed practice is with models that are very collaborative, brief intervention models that are very collaborative, like the CDOI ones and motivational interviewing ones. And here's an example where, from a study that on motivational interviewing that shows that particular piece where often in motivational interviewing you might mention a menu of options. And how, within that, something like connection to others might be something that's important that women identify that they'd like to work on, or that we signal that's something we often work on with people. And, as you're creating that kind of menu of options and choice, that, the issue of connection to others may be an important piece that may signal that, trauma histories and the potential for support around that. Or women might say more specifically that they would like support on trauma. So there's an example in brief interventions where I think, clearly it can be. Now, I said I was going to come back to the Seeking Safety model. I just wanted to mention an adaptation at the Victoria Women's Sexual Assault Center because they partnered with VHA to create an outpatient group. So we're now at a different level. This is outpatient support, where they adapted the Seeking Safety model to have 3 kind of information-oriented sessions that women could come to, where they focused on coping strategies only. You could come once a week for 3 weeks and learn coping strategies. You didn't have to sign on for the 12-week program. You could just stop after the 3 weeks if you got what you needed, and some women did. And so it's just a bit of a trauma-informed front end to a more trauma-specific 12 weeks that followed it. And Debbie Pierce and I evaluated that group back in 2005, and the women said to us that the benefits for them was the safety to explore both trauma and substance use issues, the learning about the effects of trauma and the skills that they got to manage it, the reduction in stigma and the increasing self-acceptance from seeing themselves as a person with a trauma history, and breaking through isolation, connecting with other women, developing hope for the future, et cetera. So that's an example, I think, a great example of trauma-informed at the outpatient level. And I don't have time to talk about this today, but here's a great other example of trauma-informed intake practices that the BC folks have been generating, of some of the ways of adapting intake processes in substance use services that really, indicate a trauma-informed approach. For instance, identifying symptoms rather than suggesting that people have to say whether they have trauma histories, but more, do you notice that it's hard for you to stay focused, blah, blah, blah. Going through the pamphlet that we mentioned earlier and looking at some of the signs of trauma and helping people make connections, et cetera. So that's a whole rich area. We could do a webinar on in and of itself on trauma-informed intake processes. Just wanted to mention as well the work of the fabulous work of the Jean Tweed Center, and I always include them in any time I mention trauma-informed practice because they've spent years thinking about, in the context of residential and non-residential treatment for women, about how to braid, in trauma, substance use, and gambling supports. And, here's the shortest version possible of their learnings: to look for client readiness, to be willing to work on trauma, to do lots of education with both your staff and funders, to support women's pacing, not to think that there's some kind of prescribed schedule for when someone should be ready to talk about trauma. Good clinical supervision, peer support for both staff and clients, and an ongoing quality assurance plan that gives you feedback on how the women and the staff are doing. So there it is on a residential example. Now, in a bit of, sort of promotion of the Center for Addictions and Mental Health upcoming book, I just wanted to say that Lorraine Greaves and I have been editing this book, guidebook for CAMH, on becoming trauma-informed. And there are chapters about trauma-informed work with different populations, with men, with refugees, with people with disabilities, with homeless people, women who've lost custody of their children, et cetera. And really lots more attention to different settings, outpatient, inpatient, clinics, like health clinics, psychiatric settings, and whole systems of care. So keep an eye out for that because I think it'll be really interesting. So I just wanted to sort of wrap up, talking about these, about trauma-informed practice by talking about it on the systems level, and then hopefully leave 20 minutes for us to have questions. So Rod Olford, as I was planning this, said, it's really important, Nancy, for the systems action people to think about why we need to focus on trauma-informed care in our systems development, not only on an individual level. And I started to think through this a bit, and it took me back to thinking about this document we created in British Columbia called Weaving the Threads in 2001, as we were thinking about a harm reduction system of care, right? A system of care that reflected our harm reduction principles. And as we were doing it, we created this kind of matrix, and we were thinking through you know, that in some ways in the past, the substance use field spent a lot of time in that box that has the red font for people that were ready to heal and people who were ready to change, who needed to heal and were ready to change. And, you know, it caused us to think, well, what about if people were needing to be, you know, at the point of wanting healing but weren't ready to change? What kinds of things did our system need to have for those folks? So we moved up the box to, you know, above the red box to that. And then we thought, well, you know, sometimes people just want stabilization. And they're, you know, they're ready to change, but they don't have a healing goal. They just have a stabilization goal. So, you know, what kinds of things should we be creating for those people? And I guess I'm kind of thinking about coming back to this matrix model around our work on trauma-informed practice, too, that in some ways we've thought often in the past that when people had trauma histories, we immediately had to be guiding them towards what would be the red box, right, which is intensive trauma healing, trauma-specific work for people who are ready to do that. And I think I'm trying to invite us to think about the fact there are a lot of people coming for our care who may not ever want to do the healing piece, may just be looking for stabilization, may or may not be ready for change, et cetera. And so we need to have lots of different, you know, kind of a seamless system of care that links trauma-specific and trauma-informed work, but doesn't press trauma-specific treatment on people who don't want or need it, and vice versa. So that's, you know, one of my kind of systems views that I thought might help us think through why this is so important, that the trauma-informed piece is extremely important to recognize where people are at and their interest in change. And of course, being a big fan of CCSA's work on the National Treatment Strategy, it really strikes me that trauma-informed practice has such a big role in our tiered system of care, that no matter what level or tier you're at in this system, it is critical to think about what's, you know, how we can be trauma-informed. So it may be like the Victoria Women's Sexual Assault Center thinking about working together with VHA and sort of an outpatient treatment model, or it may be people who are doing brief intervention in transition houses. It may be a whole range of folks, but we all need to think about how we might make our systems more helpful and engaging and welcoming and supportive of people with multiple issues of mental health concerns, substance use problems, and histories of trauma and violence. So, you know, it took me again to this, my favorite quote from Miller in this book called Rethinking Substance Abuse, What the Science Shows and What We Should Do About It, that really intervention is not a specialist problem, but a broad social responsibility that should be shared by many public and private sectors. And I just like that sense that I feel kind of now that we do have responsibility, given that we know the links between trauma and substance use, to really think through how we can shoulder the responsibility in our systems and in our practice. Just to underline that, we certainly found the need to think about trauma-informed practice as we were thinking about preventing fetal alcohol spectrum disorder. And one of the first things we became aware of is that, you know, the women at highest risk really needed us to think about trauma as well as substance use, as well as mental health problems, as well about social isolation. So it became clear to us that, you know, to prevent fetal alcohol spectrum disorder, we needed to do lots of quite complex trauma-informed work for the women at highest risk, like these birth mothers that were identified in the Seattle study. And in a study we did in British Columbia with women entering transition houses, we saw such an amazing shift in their substance use following a stay in a transition house. And it wasn't about whether the transition house did a significant substance use intervention or a minimal one. It was all about this linked support around determinants of health, and linking violence, substance use, and lots of pragmatic harm-reducing supports. So I'm going to just underline what we found so much in BC, that a lot about trauma-informed practice at the system level is really attending to the needs of providers, providing totally accessible and relevant training, lots of work on shifting organizations, and thinking about the link with cultural competence, and as we do the training, and thinking about some models like the models that the Provincial Health Service Authority in BC has done around Indigenous cultural competence training and communities of practice, and lots of ways of making the learning and support needs of providers front and center in this work. And so yeah, that's about it for me. Just lots of websites are included in this that take you to more resources, for sure. Here's some Canadian ones, and all of these slides will be posted on both the System Action site, the CCSA site, and the Center of Excellence one, so you can go and find these more closely. Some excellent work on trauma-informed practice by people who are delivering homelessness services, and I just wanted to acknowledge these two kits that might be really helpful to people who are thinking about trauma-informed practice. And finally, just some of the U.S. ones that I'd mentioned as well. So let's open the discussion again and think about what questions you have.
Hi, Nancy. Thank you. That was an amazing presentation. I do understand that I believe at least some people lost sound for a little bit there. So I'm not sure what happened, but we certainly do apologize for that. And hopefully some of the information will be covered as we go through the questions and answers. I believe it was just the last maybe 3 or 4 slides. A couple of questions have addressed how trauma-informed care can address the needs of certain populations, including family and other carers of clients who might have had trauma, and also specifically men with trauma. You spoke a lot to services for women. So the question was whether there's parallel services for men, both at VHA or at the general system best practice level.
That's a great question. And, I always yammer on about women because, of course, that's been my main area of work is women and substance use issues. And, in fact, that's where the most work actually has been done on trauma-informed practice. And that may not be at all surprising given the level of trauma that experienced by women in our societies. And so I have, spent more time talking about that. And this study here, this Women Co-occurring Disorders and Violence study, is one of the first main studies, multi-site studies that was done on trauma-informed practice by women who also have mental health and substance use problems. And it still remains one of them, the most amazing pieces of evidence that we have around this work. But having said that, there's lots that is beginning to emerge around men. And we've, the main people that I think have been leading some of that thinking have been, as I mentioned, Roger Fallot, who's doing work out of Community Connections in the U.S. And he's actually done a chapter on trauma-informed practice with men for the Center for Addiction and Mental Health, a book that's coming up. There are not as many services yet developed that are either trauma-specific or trauma-informed with men in mind, but they are emerging, and there is actually one in Victoria that is sort of the brother organization, I guess, to the Victoria Women's Sexual Assault Center in some ways, and some really good connections have been happening around that, but lots more to be done. I think one of the things in the U.S. that has really emerged is that a lot of the early work on trauma-specific practice in the U.S. was done with veterans who, of course, were largely men, and so there's quite a bit of that literature that's also helpful. But a great resource we found when we were doing this work from the U.S. around men of color and trauma, and I can send that the link to that guidebook as well to people. But where we found that was through this site, the familyhomelessness.org site. So if you typed in it there, I'm sure you would find it as well. But, and men, not only men, but, as I mentioned back in the various subgroups that were in the book on trauma-informed practice, is that there are really a lot of populations we need to be concerned about, including the families of people with where there has been trauma in the family. And so, these are some of the subgroups that we need to be considering, but and where we have found some examples of evidence-based practice, but it's a field I think we need to be doing lots of thinking about in terms of what is it, how might we measure it and evidence it, and really share and learn with each other about how to proceed.
Thank you, Nancy. We're getting a lot of great questions coming in now. A couple of them are dealing with the multi-sectoral approach. So, again, going back to your tiered model diagram and recognizing that...
Yes, I'm sure you do, yes. Yeah, so, I think, again, there's been some great examples of this, particularly in the homeless area, but also, work that Jean Tweed has done with, for instance, the Children's Aid Society of Toronto in thinking through what is trauma-informed practice with mothers and parents around, who have substance use problems, and also issues with child welfare, and how traumatizing the loss of custody can be, and how important it is for all of us working across systems to really be working together with a trauma-informed framework. And so they've done some really excellent work on that. And there's a chapter in the upcoming book on that particular practice that they have worked out, and including work with the Riverdale community, I don't think it's a clinic. Anyway, someone may know but they've been working a lot with Parkdale Community Services, et cetera. So I think that people are starting to figure out what the sort of cross-tier and cross-sectoral pieces of this is about. And to me, I think that is the biggest piece of trauma-informed practice in lots of ways, to ensure that people are not getting lost between systems. In BC, when we did the interview in health authorities with experts in addictions and mental health, one of them mentioned that for the men at highest risk, who had very significant trauma histories, who were accessing help from a local physician who was very supportive, one of the addictions workers often went over to his medical clinic and sat and met the men, and often even went out walking with the men to build relationship, because there was going to be absolutely no way that those men were going to feel comfortable beginning a relationship with the addiction system, and needed to be a lot more paced relationship building needed to happen between systems before that was going to be a possibility of sharing the work between the physician and the addictions and mental health providers. So it was just a great example where they figured out a cross-system way of working that was extremely trauma-informed.
One question that's interesting, the difference between trauma-informed approaches and client and patient-centered approaches.
Yeah, I knew someone would ask me that, and, it's true. There's a huge overlap. I think one of the things that is different is that piece that I mentioned as the first principle about trauma awareness. Because I think in the past we've often done lots of the collaborative piece, we've often done a lot of the strengths-based, we've done lots of things that are part of this, but we haven't specifically thought about how are we talking to our clients about the links between trauma, mental health, and substance use. How are we making sure that we are doing things like, stopping and teaching people trauma, coping skills, calming skills, grounding, whatever. How are we explicitly building that trauma awareness piece into those other best practices that also reflect a trauma-informed approach? But I think there's a trauma aspect to it, that not our systems of care, like our addictions and mental health systems of care, haven't necessarily given workers permission to name and do in the way that a true trauma-informed practice system would. And, I think the intake piece is a huge part of that. I mean, we often, do our nice supportive collaborative work much later than the intake process. But for people with trauma histories, that's all important, that we don't, rush that or force disclosure, or, as the people in DC said to me, press for compliance to a rigid intake process, right? As if somehow if we could just get all these facts down on a sheet, then we can start doing good practice. And I think for me that has that's a lot of the difference. Thinking about what it might feel like for a person to come in and be in a waiting room who has a history where they don't feel safe with their in open spaces or closed spaces for that matter. So lots of things, I think, make, physical environments as well as intake procedures and specific trauma education really make things somewhat different from just plain old good practice. But I agree, there's a big overlap.
You sort of tangentially touched on a few other questions in your answer there, but I'll just focus in on them a little bit. One of them was around the clinical and physician labeling pattern that we've seen in terms of mislabeling of trauma clients with personality disorders, and how to address that, and also going beyond just physical, for example, waiting room setups, and within, for example, a residential setting, how to translate trauma-informed practice on the actual rules and guidelines on a residential floor.
Okay, well, the misdiagnosis piece, I think, is a pretty significant one, and it comes up a lot in articles around trauma-informed practice. And one person in particular who's been really articulate on this is Laurie Haskell, who's written lots of great stuff for the Center for Addiction and Mental Health. And I think in some ways, you know, obviously we can't necessarily single-handedly take on, you know, the whole process of the DSM-5 or whatever labeling system. But one of the things we can really do is to, as I mentioned before, one of the things that we really can do is notice current functioning and notice what's going on for people in the moment, and be starting to name that for people and helping people link that to, you know, early experiences of trauma. That's common, that kind of thing. Recognizing that, you know, early histories of trauma really impair people's ability to relate, and that we can, through education and collaborative practice, choice and safety and all these mechanisms, really de-escalate and help people understand themselves in ways that may not, you know, continue that progression into them increasingly being you know, labeled in a psychiatric way, but more, as Norma Finkelstein once said when she was doing a presentation, it's really see themselves more, I don't know how she put it, but the sense of it was to see themselves as people who have this complex identity of trauma survivor, substance user, or someone in recovery, and someone with depression or whatever the other, you know, mental health symptom may be, and really being able to see themselves that's a complex identity they have that they're working on, rather than seeing themselves as pathological, seeing themselves as being, you know, all these things and more, and that it's not something to be ashamed of or whatever. It's something that they are richly deserving of support on. So I think that misdiagnosis piece is a big one. To answer the residential treatment part of it is there are lots of suggestions around that, and one of the people who's been so great at thinking through that is the group in the States in Los Angeles called Prototypes, and Dr. Vivian Brown has written quite a bit on that in various articles, and I'm sure you could find a bit of that where she, you know, they talk about, you know, not, you know, going into rooms at night with a flashlight kind of thing and whatever, creating safety in lots of different ways, and helping people when they come in say, you know, this is something that really triggers me, and so how can we create a residential climate that doesn't perpetuate that, right? And so she's done some great pieces on that, and includes some of that in a chapter in the Trauma-Informed Practice book that CAMH is coming forth with. So I think there's, you know, we're only limited by our own lack of asking the clients, you know, what's helpful, what are you feeling right now, you know, and how might we help you manage, you know, your feelings of distress in the context of a residential treatment model. When I did a bit of work with the Riverview Hospital I did a study there a few years ago, and they did a simple thing at intake. They asked clients who were coming into the mental health system at Riverview if how do they like to be treated when they get upset? Do they prefer to be by themselves in a room, or do they prefer to be out in the main area connected to others? right? So they just gave them a choice around that piece as they were coming in. And then we looked down the road at clients' responses to that, and it was really interesting. Clients said, it was so amazing to me that they asked. And, I really got a whole different sense of coming into this place because I felt like I was going to be listened to and I wasn't going to be forced into, a room by myself when that, in fact, was one of the things that happened to me as a child where I was locked in a closet for hours. And the last thing that I needed at that moment was to be afraid that I was going to be, locked in a room alone. So,
Could I ask you to forward the slide deck back to the last slide? We're getting some questions about additional resources that it would be available.
Oh, okay. Sure.
We're signing off. So just to provide that link. And just recognizing we are closing in on 2 o'clock here. So to thank everybody, maybe the second to last slide that has the links. So I'll just highlight that we do have another webinar coming up on Wednesday, April 4th that will be provided by Gloria Hyam, Joanna Henderson, and Brandy McNeil on building cross-sectoral collaboration to foster implementation of evidence-based practice, highlighting the Cape Breton experience. So sorry to interrupt you there, Nancy, and I will then leave it to you if you'd like to continue to expand, if you wanted to say some closing words or take additional questions.
Well, I don't have too much more to say. I mean, I have a lot more to say. As you can tell, I'm really passionate on this topic, right? Yeah.
Okay.
I'm just trying to see. Oh, thank you, Diane Smiley, for linking in and saying it was the South Riverdale Community Health Center that I botched back there as I was trying to give an example of the connections between Jean Tweed on those issues. So yeah, I don't know whether there's any one last question that you can see there that you think I should try and do as in my last couple of minutes.
Well, maybe one last question from Peter Pike in terms of recommending a current workbook for trauma-informed practice as a good platform to promote the work that you've been doing one final time. And then I will just say thank you so much for the time that you've taken in preparing and delivering this webinar. It's always amazing to hear from you, and I think that we in Canada are tremendously fortunate to have somebody with your passion and expertise in this area working with us.
Well, that's great. So to Peter, I might just mention the clinic's trauma toolkit too, that is online, and really encourage him to go there, because we don't have a current workbook in Canada beyond their particular work. It's a great piece, and we're building lots more, as I said, through CAMH and through the BC group as well. And really encourage you to explore some of these sites, and including the Knowledge Exchange site at CAMH. There's lots of great material there as well. And hopefully in the System Action site we'll continue to keep the discussion going on this as well, because it's great because I think we're in development and we're learning, what it is and how to do it. It's a great time for us to be having that kind of dialogue that the System Action Group can support, so that we can benefit from each other's experience. So thanks for having me, and hopefully, lots of us will continue to have these discussions together.
Thank you. I think that's definitely the intention. And again, the PowerPoint slides will be available. You can see the links and where the recording of the webinar will also be available. We do have the PowerPoint slides translated, so if you'd prefer a French version, we'll be able to send you that as well. And stay tuned also for the feedback survey. We definitely wanted to continue improving the way our webinars work, and we can only do that with your help. Thank you.